everyone, and welcome back for another Down Syndrome Center podcast. As always, I'm your host, Dr. Kishore Velody. In the next 3 podcasts, we will be discussing gastrointestinal issues that impact children with Down syndrome. With us today, and hopefully for the next few podcasts, is Dr. Arvind Srinath. Hey Arvind, thanks for being here with us today. Before we get started, could you fill us in a little bit about your medical background?
Thank you, Dr. Velody, for this opportunity. I'm glad to be here. I grew up in Connecticut and ended up going to college in Baltimore at Johns Hopkins. I ended up doing my medical school training over at University of Pittsburgh, then went back to Baltimore to Hopkins to do my residency in pediatrics before coming back to Pittsburgh for my fellowship in Pediatric Gastroenterology.
Well, we're all really glad that you did eventually bounce back to Pittsburgh to join us here at the faculty at Children's Hospital. But before we get too far into this, we should probably start with the basics. Can you tell us what gastroesophageal reflux is and how it's defined?
Absolutely. To answer that question, I'd first like to distinguish between 2 entities, the first of which is called gastroesophageal reflux, or GER, GER, and gastroesophageal reflux disease, or GERD, GERD. The first of those, GER or GER, is passage of the stomach contents into the esophagus or food pipe with or without regurgitation or vomiting. It's a normal or physiologic process and can occur several times per day in healthy infants, children, and adults. In contrast, gastroesophageal reflux disease, or GERD, is present when the reflux of stomach contents causes troublesome symptoms or complications. Now, these symptoms are dependent on the child's age and developmental level and can include, for example, in infants, vomiting in the setting of a distressed child after feeds, so not necessarily your happy spitter who has gastroesophageal reflux, or GER, and potentially fussiness or irritability after feeds. In older children, your more typical symptoms prevail, namely heartburn, regurgitation, vomiting, and potentially trouble swallowing.
All right, well, let me just summarize for our listeners what I think you're saying. You're saying that there's 2 very different diagnoses out there when it comes to reflux. The most common one is that gastroesophageal reflux, or GER, where there's some spitting up or vomiting, but it's not really causing any serious problems to the child. And then there's gastroesophageal reflux disease, or GERD, which has some potential complications. Do I have that right?
Absolutely, you're exactly correct.
Okay, great. So now that we know what gastroesophageal reflux and what gastroesophageal reflux disease are, can you tell us a little bit more about how common they are in kids in each age range?
So, excellent question. About 85% of infants will vomit in the first week of life. 60 to 70% of infants will have gastroesophageal reflux by 3 to 4 months of age. The majority of these kiddos will have resolution of their symptoms by the age of 1 year. In contrast, in terms of the true rates or prevalence of gastroesophageal reflux disease, it's a difficult thing to study because it's a difficult condition to diagnose, but GERD is usually present in about 10% of pediatric patients, and it's more common in the adolescent population. The rates of this condition go up in adulthood to 10 to 20%.
Okay, so if that's how common it is in the general population, can you give us some idea as to why reflux seems to be more common in the population of children with Down syndrome?
So that's a great question, and it's actually a little unclear as to why gastroesophageal reflux and gastroesophageal reflux disease is more common in patients with Down syndrome. The most prevailing postulate is that the nerves that supply the gut and contribute to the control of the movement of the intestines are somewhat dysfunctional. This could lead to poor propelling of the food through the food pipe and the stomach, and poor control of the valve or the blocker that prevents food from coming to the stomach back into the food pipe, all of which can mediate the symptoms of gastroesophageal reflux disease.
Thanks, Arvind. But just so our listeners can understand this completely, can I just try to summarize? So, the food is swallowed, and it goes down the food pipe or esophagus and into the stomach. And then there's a valve at the top of the stomach that's supposed to close so that the food and the stomach acid that's now mixed in with the food will stay in the stomach. But if that valve is open instead of closed, This is what causes the stomach contents to reflux back up, and hence the term gastroesophageal reflux. Do you agree with that summary?
I completely agree.
Perfect. So now that we know all this background about gastroesophageal reflux, do we really need to do anything about it? I mean, it seems like it's a pretty common condition for which we can't really treat everyone, with a medication at least. I mean, let's start with infants who are what we would call happy spitters, meaning that they're babies who spit up, so they have gastroesophageal reflux, but they don't really have any other problems associated with it, so they don't have disease. What do you do with them?
So, excellent question. First of all, with regards to gastroesophageal reflux, or GER, by itself, since gastroesophageal reflux is a process that can occur in healthy infants, there's no need to treat.
That's interesting that you say that, because I know that many parents and practitioners will try to manage gastroesophageal reflux with different kinds of techniques. Could you touch on some of these and whether there's any data to support using them?
That's a great question. Potentially controversial topics include thickening of the formula, upright positioning after feeds, and feed volume. First of all, with regards to thickening, studies have shown that thickening only decreases the height of the reflux contents. It doesn't change the frequency of the reflux events, the acidity of the stomach contents that the esophagus is exposed to. So, in effect, you're really not changing the reflux itself. With regards to upright positioning after feeds, although this technically makes sense from a gravity standpoint, it's debatable whether or not upright positioning after feeds alleviates gastroesophageal reflux disease in infants. With regards to the head of the bed being elevated in infants who have gastroesophageal reflux disease, there are studies suggesting this position may actually worsen reflux. Hence, there might not be any utility.
Well, is there any position at all that's helpful in gastroesophageal reflux in infants?
The only true position that may help gastroesophageal reflux disease in infants is the prone or face-down position, though I can't reinforce enough this is not recommended since the risks of sudden infant death syndrome, or SIDS, far outweighs the risks of gastroesophageal reflux disease with this position.
A lot of what you're saying is going to be new maybe to some of our listeners. Can you tell us where you're getting this information from?
No, absolutely. And thanks for asking that question. These suggestions and this data is summarized periodically in our guideline statement. And that association is the NASPGHAN, or NASPGHAN, and they meet on a regular basis, go over what studies have come out, and come to consensus over how things should be practiced based on the most recent literature out there.
Wonderful. Well, I think it's kind of telling that here we are almost at the end of this podcast, and we haven't even yet talked about medications for gastroesophageal reflux. I think that just goes to show that there are really many other things that we can do other than medications to manage this condition. But I know there's definitely a role for medications in treating gastroesophageal reflux disease. Could you touch on some of those now?
So that's a good point, and you're exactly right. There definitely is a role for medications in patients who have gastroesophageal reflux disease, and that's when lifestyle changes fail. Mm-hmm. The major types of medications used to help gastroesophageal reflux disease can be divided into medications that suppress acid production, neutralize acid, or surface barriers of the lining of the gut. With regards to acid suppressant medications, examples include pantoprazole or lansoprazole, but one must be wary of the side effects of chronic use, which can be risks of pneumonias and gastrointestinal infections. With regards to medications that neutralize acid, or antacids, these take effect immediately, and they're useful to be used on an as-needed basis, and they're for the patients with the occasional symptom. It's important to keep in mind that chronic use of medications like these may lead to tolerance over time in patients. Lastly, with regards to the mucosal surface barriers, these are mainly used for pain relief, and I wouldn't recommend them for chronic use or in infants due to some of their systemic side effects. The other class of medications that I like to touch upon that we don't use on a regular basis include medications to help the gut move faster, since that might play a role in the development of gastroesophageal reflux disease. And I did discuss earlier that patients with Down syndrome may have motility dysfunction leading to their reflux. But I would say without further testing and referral to a subspecialist such as a pediatric gastroenterologist, I wouldn't recommend a trial of medications to help the food pipe and stomach move faster.
Wow, thanks a lot for that great review of all the different medications that are out there. But let me just ask you this question now, because we get a lot of babies who come in and are started on one of these medications for their reflux. Is there any role for acid suppression in a baby who has no disease but just some spitting up?
There is no role for acid suppression, and actually none of these medications will prevent the child from spitting up.
And oftentimes acid suppression medication is started because it's felt that there's minimal or no side effects. But based on what you just said, that doesn't seem to be true, right?
Exactly. There are potential side effects, mainly the risk of GI infections and pneumonias.
Hey, thanks, Arvind, for clarifying all that for us, because I think it's really important for people to hear. There is a role for stomach acid. Our acid is there not just for digesting our food, but also to fight off all the bacteria and viruses that we eat every day and don't even realize it. So it makes sense conceptually that by taking that acid away, we're going to be increasing our risk for infection with bacteria and viruses we may have been able to kill off had we had our stomach acid.
I couldn't agree more.
Well, let me just ask you one final question then before I let you go. What signs should a doctor or a parent look for in a child who's vomiting or having reflux symptoms that would be more worrisome and therefore mean that they should be seen by a pediatric gastroenterology specialist?
So I think it's important to consider warning signs. One must consider conditions whose symptoms can mimic gastroesophageal reflux but warrant referral for further testing. And these include conditions that are due to obstruction, food going down the wrong pipe, or signs of potential problems in the brain, intestinal irritation, metabolic disorders. Signs of obstruction examples include food getting stuck when swallowing, painful swallowing, or vomiting that's green. Signs of food going down the wrong pipe could include coughing or gagging when eating, hoarseness, or recurrent pneumonias. And signs of potential problems in the brain could include a head out of the range of normal size, a bulging fontanelle, poor development, lethargy, or even seizures. Other possible reasons to refer to a subspecialist include poor weight gain or weight loss, masses felt on abdominal exam, or blood in the stool.
Okay, well, thanks for going through that for us, because now our listeners know what to look for and when to be concerned enough to seek out subspecialty advice from a gastroenterologist. Hey, Arvind, that was a lot of fun. Thanks for being here with me today, and I hope that next time you'll come back and join us so we can talk about more gastrointestinal issues, especially as it relates to kids with Down syndrome.
You're very welcome, and thank you again for this opportunity. I'd be more than happy to join you again for another podcast.
Well, that sounds great. I'm looking forward to it. Hey, well, to our listeners, thanks for joining us again, and as always, send us your questions to downsyndromecenter@gmail.com. Until next time, goodbye.